طيب يعني
of a 4-year-old patient presenting to the pediatrician with 3 weeks streptococcal throat infection. Okay, so 3 weeks of strep throat infection. The patient or the child is lethargic. The physician noted that the child also is pale, so maybe he has anemia. Okay. And the child's spleen can be enlargement, splenomegaly, plus lymphadenopathy and enlargement of lymph nodes on physical examination. Also, the patient shows multiple bruises on the lower extremities, which indicates what, or might indicate what, lower bleeding tendency مش هيك due to thrombocytopenia. Also, the patient has bleeding from his nose. Type CBC findings shows increased white blood cells more than normal range. RBCs are decreased. Hemoglobin is very low. Okay, so the patient has anemia and leukocytosis. So platelets also is very low. 29,000, normal between 150 and to 400,000. Okay. So picture صارت child acute presentation عنده anemia, leukocytosis, thrombocytopenia. The differential shows that all the leukocytes, or most of the leukocytes, are of blast form. Okay, so the normal lymphocytes almost zero, neutrophils are decreased, and the other differential cells. So this is what? This is acute lymphoblastic leukemia. Peripheral blood shows increase in the lymphoblasts, which are small cells with large nucleus, scant cytoplasm. Okay, with indistinct or one nucleoli. Type. The bone marrow biopsy shows hypercellularity, almost 100%. These are bony trabeculae, and in between it's only sheets of cells. These cells, لو شفناهم على higher power, they are lymphoblasts, blast cells. طيب. Here is another picture اللي هو من bone marrow aspirate. You can appreciate these cells, large cells, with large irregular nuclei, prominent multiple nucleoli, and we have characteristic what? Cytoplasmic our rods اللي هم diagnostic of acute myeloid leukemia, mostly seen in M3. طبعا M3 associated with translocation اللي هي most common translocation seen in M3 اللي هي 15, 17. طيب. This section shows lymph node, or a lymph node section shows reactive lymph node with variably sized lymphoid follicles with germinal centers. Reactive germinal centers اللي هم pale staining centers, okay? Surrounded by what? What is this zone? It is the mantle zone, okay? Mantle zone. High reactive lymph node. Okay, this lymph node is enlarged if we compare it لو تشوفوا lymph nodes normal اللي هي non-reactive خلينا نحكي أو not involved by any process, small, while this lymph node is enlarged. The other thing, it is what? Infiltrated or obstructed by this white nodules, whitish smaller nodules. Normally the section of a lymph node is soft and pink in color. So we have here effacement of this lymph node. مش مبينة عندكم، ممكن أوضحها بالسلايدز معكم. طيب. From the grossing or gross sectioning, we cannot tell if this is Hodgkin lymphoma, is this lymph node involved by Hodgkin lymphoma or non-Hodgkin lymphoma. We need what? We need histopathologic examination. This liver also is enlarged due to involvement by lymphoma. الفكرة من هون اللي هو staging of lymphoma، اللي هو involvement of extranodal tissues or sites, which upgrade the stage.
Stage 4.
Yes, and affect the treatment, the choice of treatment modalities, which treatment should be used in advanced stages, and the prognosis as well. This section also from a lymph node, you can appreciate the what? The sheets of cells, effacement of the normal follicular pattern. Normally لازم يكون في عندنا follicles. مش هيك؟ لكن here we have cellular sheets infiltrating the lymph node with what? Supracapsular or extracapsular. هي capsule lymph node. Extracapsular extension. يعني لما يكون في عندنا process involving the lymph node and extending to outside the capsule, this is alarming sign. We have a neoplastic process. Okay? So these cells are small, monotonous. ممكن نشوف كمان بس هون مش كتير واضحة اللي هي foci of proliferating centers. Proliferating centers يكون فيهم pro-lymphocytes, active dividing or active lymphocytes. The proliferation center is characteristic of what? Small lymphocytic lymphoma. If we have involvement of these mature-looking lymphocytes involving the peripheral blood, present in the peripheral blood, then we call the disease what? CLL. Involvement of lymph node SLL/CLL with leukemic picture. Yes, chronic lymphocytic leukemia. With presence of what? Of lymphocytes, mature-looking lymphocytes. And what these cells called smashed lymphocytes, because they are fragile, smudged cells, characteristic of CLL. Okay, this is another section from a lymph node. We have follicle. Okay, we have follicles. Okay, but the follicles are monotonous and destroying the normal architecture of the lymph node. لازم يكون عندنا follicles بالcortex, then we have paracortical space, we have medulla, and variation in the size of the lymphoid follicles. If it is follicular hyperplasia, reactive process. While if the enlargement is due to infiltration by monotonous lymphoid follicles, this is because what? Involvement by follicular lymphoma. It's a neoplastic process. The other hint, this is a neoplastic process, اللي هو involvement of the fat, extension to the fat. Also, this is alarming sign, and additional sign, it is a neoplastic process. So, one of the aggressive lymphomas, and most common, is diffuse large B-cell lymphoma. It's a diffuse pattern of growth, shows diffuse pattern of growth, characterized by the presence of large cells from its name. Okay, here higher picture with larger cells and multiple nucleoli, okay? The TLBL could be de novo, يعني arising by itself at older age group, or coming from transformation from lower grade lymphoma. مثال على lymphomas transform to DLBL in a phenomenon called Richter's transformation اللي هما follicular lymphoma وال SLL اللي small lymphocytic lymphoma. Characteristics of Burkitt lymphoma histopathology اللي هو star sky appearance with these pale bright foci representing macrophages engulfing the nuclear debris or apoptotic fragments. Okay? Translocation seen in Burkitt lymphoma is 814 with c-Myc oncogene mutation. Hodgkin lymphoma characterized by the presence of RS cells in 4 types. In the classical subtypes, the RS cells have the classic variants or morphology with binucleated or bilobated multinucleated cell, large cell with owl eye appearance. Okay? One of the commonest subtypes of Hodgkin lymphoma اللي هو nodular sclerosis, affecting a younger or middle-aged patient. From its name, it has a nodular pattern of growth with fibrous bands dividing the lymph nodes into nodules. One في عندنا nodule, another nodule. In between we have the fibrous bands. Other variant of RS cells seen in the classical subtypes اللي هو lacunar cells. Lacunar cells with perinuclear clearing or halo. This perinuclear clearing related to what? The processing اللي هو formalin fixation for the tissue before slide examination. This is a skull showing multiple punched out lytic lesions. Punched out يعني with defined lesions, okay? This is characteristic, and the patient is elderly, so this is characteristic of what? Of multiple myeloma, which is a neoplasm of plasma cells. X-ray also shows the punched out lytic lesion. Lytic lesions بالإكس-راي تكون translucent صح؟ radiolucent مش radio opaque. radio opaque اللي هي بتكون whitish in color مش هيك زي هيك. لكن radiolucent تكون فيها clearing related to lytic process. It is a well-defined lesion characteristic of multiple myeloma. Here, section from a bone marrow biopsy, hypercellular, infiltrated by monotonous cells. Higher power on these cells, we can appreciate what the characteristic features of the plasma cells اللي هم cartwheel appearance of the nuclei, eccentrically located nucleus. يعني لو تاخذوا هاي السيل مثلا nucleus جاي to the side والcytoplasm to the other side. Okay? They are infiltrated by plasma cells. Most of the time ممكن كل plasma cells by morphology look like the normal ones, but they are sheets and proliferating, so they are abnormal. Like in by morphology, they look like the normal plasma cell. Some of the dysplastic feature of malignant or neoplastic plasma cells being binucleated. شوفوا كيف كمان هون binucleation, enlargement of the cell as well. تمام. نبلش بآخر محاضرة في الباثولوجي. Myeloproliferative neoplasms. It's a group of malignant diseases related to clonal mutation in pluripotent stem cells. Okay, the result is abnormality in one or more cell lines. These clonal stem cells still retaining their capacity to differentiate. Like in these diseases, we can see what mature appearing cells. And still the differentiation capacity not lost. في عندنا proliferation, clonal proliferation in certain clone or sub clones of cell lines. However, the differentiation capacity is still reserved. هيك بتصير في عندنا مثلا proliferation of white blood cells or RBCs along with the neoplastic process. Presence of mutated or activated tyrosine kinases تجمع group of diseases myeloproliferative disorders lead to growth factor independent proliferation. All these diseases show what? Hypercellular bone marrow with maturation, elevated peripheral blood levels of one or more cell lines, erythroid, for example, seen in polycythemia vera, the disease polycythemia vera, إذا كان increase أو proliferation in the erythroid precursors and erythroid line. Granulocytic, if it is in the granulocytes, we will see chronic myeloid leukemia. If the proliferation in the platelets, it is essential thrombocythemia. Also, all these disorders characterized by hepatosplenomegaly due to what? Due to infiltration by the proliferating cells. The other thing اللي هو extramedullary hematopoiesis. في عنا كمان secondary foci of erythrohematopoiesis and the spleen in the red bulb. So also the erythropoiesis or hematopoiesis will take place in these foci. So we'll have enlargement of these organs. As you will see also, we have many overlapping features between them. The CML is chronic myeloid leukemia characterized by the presence of BCR-ABL fusion gene, Philadelphia chromosome. This also seen this translocation in which leukemia? Exactly, the adult type, مش هيك؟ The adult type shows this BCR-ABL fusion gene. Polycythemia vera, almost all cases shows activating a mutation in tyrosine kinase called what? JAK2. Essential thrombocythemia and primary myelofibrosis, 50% of cases shows mutation in JAK2. Okay? طيب نحكي عن CML, chronic myeloid or myelogenous leukemia, affecting adult between 25 to 60 years. Stem cell disorder characterized by massive overproduction of normal appearing but dysfunctioning granulocytes. Differential for this overproduction of normal looking or mature looking granulocyte is what? في عنا يعني overproduction of granulocytes اللي اسمها leukemoid reaction due to infection or stresses or inflammatory process in the body, autoimmune diseases for example, or certain diseases. لكن the difference between leukemoid reaction and CML rely on the absence of the Philadelphia chromosome, BCR-ABL, بيكون negative بالleukemoid reaction while positive in CML. Also differential granulocytosis, increasing granulocytes, other myeloproliferative disorder. We will see that we have granulocytosis seen in polycythemia vera as well as essential thrombocythemia. So it is not easy diagnosis للمyeloproliferative neoplasms. A lot of overlapping between them. وممكن نشوف one feature with other other diseases. حكينا الفيلادلفيا chromosome characteristic of CML. This hyperprotein has a dysregulated tyrosine kinase activity with constitutive signals that lead to growth factor receptor activation. Okay? Mimicking growth factor receptor activation. يعني هو continuous tyrosine kinase activity and overproduction of mature granulocytes. Laboratory findings. Bone marrow biopsy shows hypercellularity with mature granulocytes. Granulocytes, myelocytes, band cells, promyelocytes. All stages of differentiation of granulocytes will be seen. Megakaryocytic hyperplasia early in the disease. Megakaryocytes اللي هم platelets, large platelets cells. Also, we will see low or absent leukocyte alkaline phosphatase score. This is an enzyme reflecting the activity of granulocytes, leukocytes, alkaline phosphatase. In CML, it is absent. Why? Because, okay, we have a granulocyte, but disordered or abnormal in function. On the other hand, in leukomoid reactions, this lab is what is high, because we have increase in the granulocytes while the granulocytes are functioning normal. Here you can see sheets of granulocytes, here the segmented neutrophils, eosinophils, basophils, okay? White blood cells exceeding 100,000, circulating cells حكينا different stage of maturation of granulocytes, neutrophils, metamyelocytes, myelocytes, basophil and eosinophils. The platelets increased early in the course of the disease while late will be decreased. The patient will experience mild anemia as well. Shot for CML is the myeloblast should be less than 10%. Clinically, this disease is of insidious onset, slowly growing, with no specific symptoms. Like sometimes the first symptom is dragging sensation in the abdomen due to enlargement of the spleen. يكون في عندنا tension sensation in the abdomen due to splenomegaly. So non-specific خلينا نحكي symptoms from weight loss, anorexia, fever, anemia, infections shared with all neoplastic processes. CML ممكن نقسمهم into different stages or phases. Chronic phase can last from 1 to 5 years and it is unpredictable. يعني ممكن تكون 3 years, 1 year, 5 years. Characterized by mild anemia, mild to moderate elevation of white blood cells with blast less than 10%. The other phase is the accelerated or transformation phase, seen in 50% of CML cases. بصير في عندهم transformation or accelerated phase, يدخلوا ب accelerated phase with increased white blood cells despite the treatment, worsening anemia and worsening symptoms, increase in white blood cells, worse anemia, thrombocytopenia, and increase in the blast percentage between 10 to 19%. Now the blasts are increasing in the blood or the bone marrow. This related to acquiring a new mutation and cytogenetic abnormality. خلاص بكفي صوت. يعني لازم القصة تخلص at certain point صح؟ طيب. After the transformation zone ممكن يصير في عنا transformation أو الaccelerated zone يدخل البيشنت ببلاستيك phase وبلاستيك crisis when the blasts in the bone marrow or peripheral blood exceeding 20%. طبعا not all patients with CML بيمشوا بالترتيب هذا إنه chronic phase, accelerated phase and plastic crisis. 50% can enter the plastic crisis without being in the transformation zone. Okay? So you can blast more than 20. And this transformation, of course, associated with what? With worse prognosis and related to acquiring new mutation. What kind of a blast seen in the plastic crisis in AML, and transformation of CML to mainly to what? 70% of the time to AML, and 30% could be what? Of ALL type. This explained by what? The mutation originally affecting the very early pluripotent stem cells that will differentiate to lymphoid progenitor and granulocytic progenitor. تمام؟ يعني early in the differentiation, very primitive cell acquiring the mutation. لما يصير في عنا blast transformation acquiring additional mutations, stem cell or progenitor cells related to its stem cell characteristics and to differentiate into lymphoid blood, okay, giving the ALL crisis. يعني هي كانت CML وإجوا تحولوا ل AML مفهوم، okay؟ لكن لما تتحول ل ALL معناته we have very primitive cells مسؤولين عن الترانسفورميشن اللي هم primitive أو pluripotent stem cells. اسمهم pluripotent stem cells that they can give either granulocytic progenitor or lymphoid progenitor. طيب هلا في عنا targeted therapy used for patients with CML اللي هو الإيماتينيب. Imatinib or Gleevec is a tyrosine kinase inhibitor inhibiting the hybrid protein PCR ABL and inducing complete remission. Other modality of treatment in young patients or resistant cases is a bone marrow transplant. اوكي هلا البوليسايثيميا هي معنى بوليسايثيميا malignant او مش malignant خلينا نحكي increase in the number of RBCs. This increase it could be relative increase due to hemo concentration in patients with dehydration due to vomiting and diarrhea for prolonged time, can be nisbi, okay, hemo concentration, or absolute true increase in the red blood cell count. This true increase in red blood cell count also can be primary due to malignant clonal process, which is called polycythemia vera, or secondary to increased erythropoietin level. Erythropoietin is like a growth factor for the erythroid precursors that lead to proliferation of red blood cells. طيب هلا secondary causes that lead to increased erythropoietin level, lung diseases that lead to hypoxia, smoking, cyanotic heart diseases, high altitude living, or paraneoplastic syndromes. Paraneoplastic syndromes اللي هي في عنا certain tumors secrete certain mediators, hormones. Example, renal cell carcinoma, hepatocellular carcinoma, secreting what? Erythropoietin and associated with development of polycythemia, secondary polycythemia. The primary polycythemia اللي هي polycythemia vera. It's a clonal process lead to the expansion of red cell mass with somatic gain of function of mutation in JAK2, which seen in 100% of polycythemia vera cases. طيب all the three lines hematopoietic lines are affected. زي ما حكينا في عنا overlap. ممكن other hematopoietic lines affected in any disease of these MPN. The myeloid, erythroid, and the megakaryocytes in a picture called panmyelosis. But the clinical symptoms and signs related to increased blood volume and viscosity due to red blood cell mass increase. The findings are expanded red cell mass, splenomegaly, bone marrow hyperplasia, and leukocytosis. طيب. To diagnose polycythemia vera, major criteria: the hemoglobin more than 18.5 in males and 16.5 in females, presence of JAK2 mutation. Both major criteria should be met to diagnose polycythemia vera, and one minor criteria: bone marrow with panmyelosis and prominent erythroid, granulocytic megakaryocytic proliferation, low serum erythropoietin, and endogenous erythroid colony formation. ايش يعني هاي؟ If we take an erythroid colony من البون marrow in vitro outside, if it grows, okay, and proliferates, this means it is what? Erythropoietin independent growth. تمام؟ it has a genetic mutation from inside that leads to independent growth of these colonies. So you need both major criteria plus one criteria, or one major and two minor features to diagnose polycythemia vera. The bone marrow will be hypercellular, of course, due to hyperplasia in the precursors. Peripheral blood high red blood cells and white blood cells platelets count, and basophilia. Basophils are increased. Hematocrit more than 60. Granulocyte count also is high and can be more than 50,000 cells per microliter. طبعا هون في عنا ايش؟ هاي picture the granulocyte count is increased in a picture called leukomoid reaction اللي حكيناها بالبداية. في عنا leukocytes increased. لكن differentiated from the CML what؟ اللي هو الانزيم leukocyte. الانزيم related to the leukocyte activity here is increased because these granulocytes are normal and mature, okay, functioning granulocytes. While in CML they are disordered granulocyte, okay. Also the erythropoietin level is low. حكينا. طيب. The presentation older age group. Main manifestation related to increased blood viscosity and vascular stasis, slow flow of blood. Also we have thrombosis and infarction. So we have heart infarction ممكن, infarction in the spleen, thrombus formation, the hepatic vein thrombosis, which will lead to hepatic congestion and hepatomegaly, and followed by cirrhosis in a syndrome called Budd-Chiari syndrome. Hemorrhage due to excessive increase in the blood volume, okay, and abnormal platelet function. We have hemorrhage, okay, due to in part increased blood volume, and the other explanation, their platelets are abnormal. So we have thrombosis and we have hemorrhage. Presentation of patients with polycythemia vera may be lethargic, redness and warm sensation due to increase in the blood volume, headache, weakness, and hypertension, pruritus, especially after hot baths, due to degranulation of basophils, release of histamine from the basophils. حكينا في عنا basophilia. also seen in polycythemia vera. Also, the patients may present with what? With gout and hyperuricemia due to what? High level or fast turnover of cells. This is congested plethoric liver, enlarged due to congestion of the blood. Treatment for symptoms, it is repeated phlebotomy, اللي هو سحب الدم, okay? Can relieve the symptoms and decrease the blood volume. Proliferative phase in polycythemia vera, we have erythroid proliferation. And we have another phase, the spent phase. Spent phase اللي هو transformation into fibrosis. Specifically, bone marrow fibrosis seen in 15 to 20% of polycythemia vera cases. Also, the patient is at risk of what? Transforming into blast phase or crisis with AML development in 5 to 10% of cases with polycythemia vera. Again, until you appreciate the overlap between all these diseases. أهم شيء نعرف any characteristic feature in each one of them. Okay? Mutation, certain symptom, presentation. Okay? هاي أهم الأشياء. لكن معظمهم في كثير overlap between them. Even in diagnosis, they are not easy diseases. طيب. Essential thrombocythemia with the clonal stem cell disorder characterized by elevated platelet count. We have a hyperplasia of large mature marrow megakaryocytes with no significant granulosis or erythrobiosis. Early in the course of thrombocythemia, ممكن ما يكون في عندنا symptoms. However, the patient will develop hemorrhage or thrombotic episodes due to non-functioning platelets. Okay, it is proliferating, but they are non-functioning or abnormal function. So the patient may present with recurrent GI bleeding, epistaxis, venous thrombosis, pain in palms, soles, and toes, iron deficiency due to recurrent bleeding episodes. Risk of transformation into acute myeloid leukemia seen in 10% of cases. Primary myelofibrosis, chronic myeloproliferative disorders characterized by bone marrow fibrosis and extramedullary hematopoiesis in liver and spleen. In the peripheral blood, we will see immature white blood cells and immature RBCs اللي هم بيكونوا nucleated RBCs erythrocytes plus teardrop RBCs. طب ليش بصير في عندنا fibrosis في البون marrow due to neoplastic process affecting the megakaryocytes? These neoplastic megakaryocytes secretes platelet-derived growth factor and transforming growth factor beta. Both are fibrogenic factors inducing the deposition of fibrous tissue in the bone marrow. The bone marrow is hypercellular early in the disease, but after that will be hypocellular and diffusely fibrotic. Okay? Peripheral blood, we have anemia with progressive worsening presentation. Blood film shows teardrop cells in the RBCs. Platelet normal or elevated early in the course of myelofibrosis and decreased in number late. حكينا كمان picture of leukoerythroplastic blood picture, presence of blasts and immature cells in the peripheral blood. Characteristic of myelofibrosis is the dry tap feature. لما نيجي ناخذ bone marrow aspirate from the bone marrow, it will be dry. The process or the sample will be dry because of the fibrosis involving the bone marrow. There is risk of also plastic formation seen in 5 to 15% of cases. These are the teardrop cells, and here, okay, another one, teardrop cells characteristic of أو seen in myelofibrosis. criteria مش مطلوبة. هون في عنا شوية comparison between the 4 types of myeloproliferative disorders. طيب آخر شيء اللي هي المyelodysplastic syndrome ال MDS. It's a clonal disorder of hematopoietic stem cells characterized by ineffective hematopoiesis. The bone marrow is hypercellular, لكن reaching certain level of maturation don't proceed more than this, so the peripheral blood will show what? Hypocellularity. There is no production of mature blood cells. Okay, so we have pancytopenia in peripheral blood and hypercellular bone marrow. The bone marrow, hypercellular due to infiltration by dysplastic primitive cells affecting all cell lines, megakaryocytes, erythroid precursors, and granulocytic precursors. Hypercellular, congested bone marrow, pancytopenia at the peripheral blood, dysplastic feature, and the precursor cells in the bone marrow. Okay? Myelodysplastic syndrome. طيب كمان معلومة مهمة إنه it could be idiopathic primary or secondary due to radiation or alkylating chemotherapy. حكينا بالبون marrow, the all cell lines will be affected with this plastic feature. The erythroid will show megaloplastic erythroid precursors, enlarged precursors here. These are precursors of RBCs, are enlarged with abnormal nuclei and ring sideroblast formation, the erythroid with iron deposition in the mitochondria. This is abnormal and a dysplastic feature affecting the erythroid precursors. The myeloid dysplastic feature, abnormal granulation in the cytoplasm or abnormal segmentation in the nucleus. Nucleus normally between 2 to 5 segmentation. It will be either hyposegmented or hypersegmented with this plastic feature. Megakaryocytes, called small megakaryocytes, with single small nuclei or multiple separated in nuclei. Affecting older age group with signs and symptoms related to the pancytopenia. So we have infection, anemia, and hemorrhage. The AML risk transformation to AML is high, from 10 to 40%. The prognosis is variable, like in maximum up to 29 months survival time. Supportive treatment to the symptoms with chemotherapy or bone marrow transplantation. This for young patients because this procedure can't be tolerated by older patients, the transplantation. طيب here آخر شيء اللي هي الكيس ل 42 old adult platelet count has 87, which is decreased. Hemoglobin is 10 decreased. White blood cells 100,000 89,000 increased. هلا ال CBC or differential shows increase in the white blood cells, the segmental type cells. The leukocyte alkaline phosphatase score is low, so we have increase in white blood cells, but they are non-functioning. Leukocyte alkaline phosphatase. طيب, what cytogenetic or karyotypic abnormality seen in such patient? It is Philadelphia chromosome in CML translocation 922. Okay? طيب. يعطيكم العافية.